Hello, my name is Pam Greene, and I will be spending the next 20 or so minutes with you talking about behavioral health and primary care team development as part of the Tex-CHIP grant. And it's really exciting to me to be part of this because in my way of thinking, this is what healthcare should be. When I talk about the integration of behavioral health into primary care, I want to clarify what I mean by behavioral health, and it is the mental health and substance use services combined. Integration of behavioral health and primary care means changes in the workforce and the way that we think about the way we deliver care, changes in clinical operations as well as administration. It's definitely beyond increasing access to care, although that's a part of it and it is important. It's beyond co-locating. It doesn't mean that everybody will be moving their offices into the same suite. Actually, I think that would be very nice, but we can have the integration and have the behavioral health component be across the city or county or even across several counties from the primary care providers. It is transformational when we start thinking about it, and it could bring profound changes and really take healthcare to an entirely different level. Two important resources that I want to draw to your attention are available and free to anyone who chooses to download these. One is Leading Change 2.0, and it is about advancing behavioral health of the nation. And then the other one is a quick start guide. I'll refer to these at different times, but I wanted to be sure you had access to them. Other strategies that we think about in terms of like workforce development, we're going to be thinking about well-trained workforce, and it's the foundation to the effectiveness of the delivery system. And I don't think I needed to tell you that, but there is a need for support and strength to expand the behavioral health workforce and improve behavioral health knowledge and skill in those in primary care or not considered behavioral health specialists. Primary care providers have a broad spectrum of what they need to know, and they need to know it across the lifespan. They can't be experts in all areas. They are on the front line of caring for people, though, with mental illness. I'll use an example with depression. We know 77% of prescriptions written for antidepressant medications are written by primary care providers. That really tells you a lot right there and begins to put in perspective how much work primary care providers are doing with people who have behavioral health issues. We also know that about a third of people with depression end up not being treated sufficiently. That also tells you a lot. People in primary care are doing the best job they can, but they need to have augmentation or support. Just like if someone has a cardiac issue, the primary care provider is likely to at least consult with a cardiologist. So Quick Start, the reference I mentioned, really is a step-by-step guide to help beginning with a self-evaluation of your organizations. And it's great that you're tuning in because that's another part of this. Before we jump into things like workforce development and strategies to look at the team, I want to make several points very clear, and that is behavioral health is essential for health. Prevention does work, treatment can be effective, and people do recover. And it's important to really have those ideas in mind as we proceed. I want you to think about this vision that you have here on the PowerPoint slide. Two cogs. The one represents the primary care provider and their team, and the other is the behavioral health team. Ideally, if they're treating the same person, they're communicating with each other. However, we know sometimes that happens and sometimes it doesn't. When we talk about the integration, this is more the picture that we're trying to get at. The person is in the middle, and each of those little cog pieces on the cog wheel represents one of the people on the team. That's going to change from person to person, so I didn't label each one. The cog wheel isn't in a position to stay still. It moves. And as with the change within the person and their needs, the wheel may turn around and be fluid. And sometimes not all people need each member of the team. So you think about the person who's newly diagnosed with diabetes may need a nutritionist. The person diagnosed with depression will need a behavioral health specialist. So this team changes based on the individual person and based on how that person's needs change. And from time to time, it won't be an individual, but the individual with their family members and significant others. And again, I don't want to create an unrealistic image of this team. While it would be nice to think of the team getting together and sitting around the table in one room, it often is spread across various facilities, but we still want to integrate and behave together as one with the care of this person and all of their needs at the center of attention. So I want to spend just a minute here with the idea of patient as member of the team. That's not a new concept, but the reality is we give it lip service more often than not. We really need to orient individuals as to what their role as a team member, in fact, the center of the team, happens to be. We need to help them not to be a passive recipient. We need to help them negotiate and collaborate. And many of you probably are thinking, well, patients today can be very well informed because of the internet, but just as many are misinformed because of the internet. So we also are in a position of helping people sort out what is best information for them. So now back to an organizational perspective. What will it take for an organization to truly become some place where integration of behavioral health and primary care are provided? Well, first of all, there has to be a true value for whole health. The care needs to be collaborative, and everybody has a responsibility for successful clinical outcomes. No finger pointing. Behavioral health is not an add-on. It's completely embedded. Just as I mentioned earlier, is if you have a person diagnosed with diabetes, you would not think of the nutritionist as an add-on. They're essential to the team. Same when it comes to behavioral health. Behavioral health clinical staff are essential. One of the things that can help with this is the Quick Start Guide. It helps you ask yourself the questions you need to have in order to really establish where your starting point is. Is there a champion, somebody who's passionate about having behavioral health and primary care integrated? If you don't have one identified, you want to find that individual or individuals. They're there, but they may not be very vocal. Do you have already a good working relationship with at least one clinician from the behavioral health community? And you want to think about not having that relationship with them only when there's a crisis or an emergency, but stay connected. They're great for medication use conversations, diagnostic clarifications, especially now that we have DSM-5. When there are co-occurring conditions, general treatment philosophies, you again want to build that relationship so that when it comes time to work in a shared patient, that you're in a good shape for that. You also want to ask, are you screening for behavioral health issues with an evidence-based tool or tools? HRSA has some great resources online, but that behavioral health clinician also will have some that they can talk with you about, ones that are quick, easy to use, and fit for your practice. When you think about outcomes, is your care effective and efficient? How do you incorporate behavioral health into all of your measures? Start small. The National Association of Community Health Centers is another tool that helps with this kind of measure process. Then you think about team development. And I like to use a classic model with predictable stages that you may be very familiar with. But when you're in the midst of something, sometimes it's hard to remember all of those stages and that it's important to go through them. And the purpose of developing a team with behavioral health and primary care is that the needs of the patient will be better met, and remembering that the patient is truly one of the team members. So you go through that stage of forming, and in that, people come together for the care of this individual, and everybody has value. It's very helpful at first to establish what role everyone's playing and who's responsible for what, and reminding everyone that each person has significant contributions to make. And you learn to trust each other with mutual respect and sensitivity. And you develop that shared model of understanding. And again, the focus is on the whole. But storming is inevitable. Whenever two people come together, there are going to be different ideas. Conflicts occur, and you want to decrease the unpleasantness of that conflict, and that is done by focusing on what you want for the outcomes and striving to find that common ground. You want to honor each team member and deal very transparently and respectfully when conflicts do come up. And it's worth investing up front with that role clarification back in the first stage of forming and reconciling any differences that may be emerging. Then you reach the point of norming. What are the routines? What are the expectations? Other differences may be addressed. And you target these with open discussions so that you can head off disagreements and make them not the focus, but stay focused on the outcomes you desire with the individual patient or person. And finally, then, performing. The team's cohesive, you're productive, you adapt to the changes, and the changes are going to occur, and certainly you navigate the process together, always including the person at the center. And when it gets tricky is when it comes to decision making. Team members have to consistently collaborate and resolve any patient problems. And the reality is, most patient care issues today are too complex for one individual anyway. So this is very helpful to have it addressed by multiple disciplines. Leadership typically needs to be inclusive unless there's a genuine emergency and there isn't time to consult one another. Now we want to get a little bit beyond the stages of the team development and kind of almost summarize with the idea of communication. Again, it's going to be cooperative and collaborative, and you really want to promote or foster the optimal use of each team member, capitalizing on everyone's strengths. That means that there has to be mutual respect, and if you don't know what another team member can contribute, ask them. They'll tell you. You want to prevent duplication and decrease the gaps and really facilitate sharing of patient information. And it's essential that you figure out how patient information will be shared to maintain HIPAA compliance and confidentiality. Timeliness has to be considered. Truly, last week, I heard of a patient care group that was missing a couple of key team members, so they texted information. The problem was one telephone number was entered incorrectly. They received a response back from their text to say, I have no idea who this is or what you're talking about. It's dangerous, so you really want to think about very carefully how you communicate, what you communicate, timeliness, all of those kinds of things. And in the end, all of this is going to enhance your practice. That is that performing stage.
Hello everyone, and thank you so much for being here today. Today we're going to be talking about behavioral health and primary team, that concept, and kind of implementing that. But before we get started with our discussion, I kind of wanted to just go around and have everyone introduce themselves and tell our audience a little bit about what it is that you do.
Sure. I'm Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I specialize in mental health. Currently, I work in specialty mental health at our VA here in Corpus Christi.
And I'm Dr. Pam Greene, and I'm on faculty here at Texas A&M Corpus Christi, the College of Nursing and Health Sciences. My background is in psych mental health nursing, and I worked in that arena for about 39 years before coming here.
I'm Kristen Hines. I'm an LPC, and I work in primary care and mental health integration at the VA outpatient clinic here in Corpus Christi.
Thank you all for being here today. So one of the things that I wanted to sort of start our discussion with was just kind of talking a little bit about some of the opportunities that you envision with integrating behavioral health and primary care. Can you tell us a little bit about that from each of your disciplines?
Who wants to go first?
Okay. Well, I think as you look through the different modules, and I realize this may be for some the starting module, it's beyond just being in the same place or beyond having a contact that you can consult with. It is literally about coming together for teamwork. And so I think in terms of opportunities here, the opportunities are huge because we're really not functioning in a lot of areas at that level just yet. So that said, I think there are many chances for people to rethink how teamwork is done in the area of integrating behavioral health in primary care.
Certainly.
Yes, and kind of thinking about this when we started this at the VA in Corpus a few years ago. So I'm currently now in specialty healthcare, but I started out with primary care mental health integration, which is now where Kristen is at, and just how it has changed over the last 3 years from when I came on board. And, you know, some of the barriers and things that we had to integrating that. But we got there, you know, and it only took a few years. And while there's still some hiccups and still a little bit of rough road, it's a demonstration that it is possible to get to that level of integration. When we first started, we had 3 of us. You know, there was a nurse, an LPC, and myself as the prescriber. And now we have a team of 10, and they're all very busy keeping up with being able to help patients in different ways. And I use that as an example to show that there is really a lot of benefit. It's just getting the system to see it, to be able to fully expand on it.
Absolutely. And you mentioned some barriers that you had experienced, some hiccups that you kind of went through during that initial phase. Would you be able to kind of talk a little bit about that?
One of the biggest ones was kind of a lack of understanding of what the service could provide.
Okay.
There was I got quite a few at the beginning that were just I'm not sure why I'm here. I don't really understand why they told me to come see you, instead of the understanding that I'm going to see you because I'm struggling with something. But part of that was because the primary care providers didn't really understand why they were sending them to me. They came up positive on a screen for depression, so they sent them over. They weren't really sure what we did, so they weren't really sure what to tell the patient to expect. So the patient then comes into your office and who are you? Why am I seeing you? And while there's still a level of that today, I think there's more understanding of what this service can provide. And one of the ways that we addressed that barrier at the time was really trying to talk to each of the primary care physicians individually, and this is what we offer. This is how we can help your patient. And then being available to do exactly what they said. We implemented a rotation schedule of same-day access providers, which I think they're still following today. So there's one person who is assigned that day. So if a primary care provider has somebody they need to be seen, they can be seen right then. At the beginning, we did not have enough providers to be able to do that, so we had to schedule patients back. And that didn't work as well, because then the primary care physicians are like, well, do I really need your service when I can just send you an alert in the chart, versus using that service? And so, as I said, one of the ways we addressed that was coming up with a schedule so that we were available and we could explain to the primary care providers that same day.
One of the things you mentioned was in the beginning, the patient wasn't real clear why they were there to see you, and that probably stemmed from the fact that the primary care provider wasn't exactly sure. And I think one of the things to keep in mind in this model is that the team is built around the patient, and the patient is part of the team. So often in the process and over time, we have to coach the patient a little bit about their role on the team. They're not a passive recipient, that they need to be asking questions, challenging if something doesn't seem right to them, and we can coach and encourage them. And the team is built around their needs, so every team will be a little bit different in terms of who makes up the team, which also is one of those challenges, because just when you figure out how I work with you and you, then the next patient comes and I might need you instead of you. And so it's always in that flux of figuring out, exactly how we're going to put this grouped together for each individual to get the best needs met.
And I think it's important for each of the team members to understand that, because oftentimes the patient doesn't.
Right.
You know, this is a new era of healthcare, having the patient as part of the team member, because traditionally that's not how it has been. And so some patients are, why are you asking me this? Why, you're the provider, you tell me what to do. Like, well, no, you're a part of the team. You are a part of making these decisions. And once they get a little bit more on board with that, they tend to do better medically and mental health, because they feel like they have a measure of control over this and a measure of buy-in. And so they're more likely to engage in what you're trying to get them to do, whether that be take their insulin, take their blood pressure meds, or apply proper sleep hygiene, whatever the case may be.
Yeah, and it's interesting to think too that it's not just mental health integration to primary care, it's who's on the mental health team, which is a multidisciplinary team.
Yes.
You know, we can use nurses for case management and care. We can use different prescribers along with counselors and psychologists. So it's not just we're throwing mental health in there, it's who makes up mental health, and then how do all of those disciplines go into primary care and work with primary care nurses and primary care pharmacists and primary care doctors. So there's a lot of different levels of integration that have to go into it. So it can take a little bit to get moving and get going, but once everybody has their defined role and is able to explain their role to everybody, the collaboration really starts to kick in there, I think.
And it can get pretty complicated, because I came from a setting where we also included the chaplain when it was relevant. And the chaplain may or may not be then the person that was on the team. Depending on the person's faith beliefs, he might reach out within the community and bring in a different clergy or faith leader. We had a nutritionist that could be available, as well as the rehab person and the substance abuse specialist. And so, yeah, it's like it really gets tricky at times. And you don't want to overwhelm and bombard all at once either.
No,
You know.
Either from the patient or the provider perspective, because our default defense tends to be, this is my area, I don't want you touching it. This is where I am comfortable operating within, and this is where I'm going to stay. And so if you overwhelm them, our default is to tend to go back to that. And so really kind of working on, these are the areas where I can be adjunctive to your area, where I can help in your area, where this other member of the team, this is where the social worker can come in, this is where the counselor can come in to help you within your area.
And really being real clear with everybody's roles and scope, because how many do you need, who do you need, and who's doing what, because there is overlap. Like I'm thinking about a psych mental health nurse practitioner and your role. There's a big overlap, but they're not the same. And so would you need both? And you have to, probably not in most cases, I would think, but it always has to be sorted out. Or if you have an LPC, do you really need a psychologist and social worker added in? Maybe for some things, but maybe not for most. So really have to understand each other's roles. And I know it's probably true of your disciplines, but a nurse is a nurse is a nurse isn't true.
Correct.
It's like your experience level is different than, say, somebody just beginning in the field. And so that makes a difference too when we're putting the teams together, is knowing even with their particular discipline or profession, their level of expertise is going to matter.
Or specialty, absolutely. And I think this really starts at the administrative and supervision level, making sure that everybody is on board. Supervisors are helping their service line figure out what their role is and how we can work together as a team, modeling that integration and really, like you said, championing it and making sure that people are on board and getting it going.
And so we've talked a little bit about this from the perspective of the administrative level and the systemic level. But can you guys talk a little bit about the culture of engagement as far as utilization from the patient's perspective? Dr. Greene, can you talk to that a little bit?
I think it goes back to what we maybe touched on earlier, and that is the patient understanding, why do I need all of these people and how are they all going to be helpful to me? Can't I just go see this one? But once they understand, I think they are much more likely. I know in one setting where I was, the patient would come very much prepared with their own agenda and who they wanted to ask questions of and what they wanted to report back, and took a real active role. But it takes coaching to get people and patients to that level. Some patients, and it's we talk sometimes about culture. Well, the culture of generations, you know, and some generations, in an older generation person, they expect the healthcare provider to take care of them. Just tell me what to do. I may or may not do it, but tell me, as opposed to, and I don't want to just stereotype, but other people who are actively seeking out information, say through the internet or whatever, they come as informed consumers, and they'll come with suggestions and ideas, not always well informed, but informed nonetheless. And so I think that it's up to us to kind of honor their interest and engagement and steer them gently if they're off track, or, you know, really provide good education and information as to why we're doing what we are doing, and really do treat them as a partner in this process. Because we know once they walk out the door, it's all on them whether they do anything we've asked them to do.
I've seen a little bit of that culture shift within the VA since we integrated primary care mental health. As I said earlier, that's where I started out, but now I'm in specialty mental health care. And patients now that are new to me that have gone through PCMHI and then ultimately require a higher level of care and end up in specialty mental health, they're already well versed with the team model because they've already seen it. Whereas 2 years ago, I would get a lot of blank stares and, why are you asking me what I think about this antidepressant? You're the doctor. You should just tell me what to do. As opposed to now that they've kind of been through this collaborative model, they start to say, okay, well, how is that going to work with my diabetes medications? And how is that going to work with my therapy? Do I really need to be on this medication, or should I just do the depression group that you're recommending? You know, they're much more involved in their healthcare. And don't get me wrong, I still have some that are, particularly of the older generation, that are very, no, I just want you to tell me what you think is best. I trust you as my provider to do what is best for me. But I'm seeing a culture shift towards I am a part of my team. And it's really kind of interesting to see, and I don't know that I ever thought really about it until starting to do this series, that really has been a shift.
Well, and coming from a psychiatric background in inpatient, that's been kind of a model first in terms of that. But again, it can be a shift with people really learning their role as a consumer in this. But also, we have the opportunity to model for them. We may not invite somebody to be part of the team directly, but to be able to share with the individual patient, you know, I'm going to consult, so I'm going to get back to you. And I think that's helpful for them too, for individuals to know that even with a team that's pretty comprehensive, we still may need to go outside and consult, and to really convey to them that we are doing everything we can to provide holistic care and cover them as a whole person, and stop breaking them into compartments.
It allows for the patient to become their own advocate for what they need, and it really empowers them to ask for a service if it's there and they need it.
Yes.
So it sounds like it's almost a responsibility of from an administrative and practitioner perspective, but also on behalf of the patient as well. It's really quite a collaborative way to kind of approach healthcare. And
Yes.
it sounds like when you have the buy-in from that patient, that's really kind of the key to opening up all the other doors.
And initially, not everyone is able to. They may be so depressed, for instance, that they don't have the energy to self-advocate for themselves, and they feel no power, and that's part of our outcomes as we measure, as we see them taking more and more ownership and more responsibility and more activity. But it can take a long time to get there.
Yes.
Absolutely. So with all that being said, what kind of stigmas do you think, kind of given where we're located here in South Texas, what kind of stigmas do you think may be tied to integrating behavioral health in primary care?
I think
some people are still resistant to it, even though it's a gentler welcome to mental health versus going to a specialty clinic. I think there's still some resistance there, like, I don't need this, I'm fine, I can manage on my own, I don't need medication, I don't need therapy. But I think particularly when you're addressing the health and behavior issues, it shows the patient that, like, okay, maybe I just need a little help with motivation, or maybe I just need some tips on how to sleep better, or how to manage my time a little bit better. And then it eases them into it and helps hopefully address that stigma a little bit more and say, like, okay, well, it doesn't mean that so many people say I'm crazy if I need mental health. It means I just need a little bit of help here and I need help figuring it out.
But I think you bring up a good point about what other people say, because sometimes that stigma is kind of imposed on a patient. They may be recognizing that they need that care, but they may have family members. They're like, there's nothing that's that wrong with you, or you know, just get up out of bed, just go to work, or whatever it may be. So I think the stigma still comes out. Sometimes it's just more subtle, sometimes not so subtle. I know that we do what's called tabling events, where we're trying to raise awareness even with college students, and we notice that there may be 5 different tables offering different services around campus. We know our table will be the least visited in terms of direct, so we have to do a lot more to reach out in terms of giving candy and things like that to entice, to get our message, because it's still hard.
Absolutely.
There very much is still a stigma, and again, even in specialty care, by the time they get to me, there's still a little bit of hostility. Although those that come through primary care mental health have had a chance to have that stigma starting to be broken down. And I think that really needs to start at the team level to be able to help the patient see that. That this is just another member of your healthcare team. This is just another way to help you feel better, to have the quality of life that you want. And when you get the rest of the team's buy-in, they can sort of paint it as a nice picture for the patient. The primary care provider has a chance to explain, well, I know that you're struggling with being able to sleep and you don't like medications. So I've got this other team member that can really help you learn ways that you can potentially improve your sleep without having to go down this medicine route, you know, as an example. And if each of the team can kind of help decrease that stigma by making it normal, just making it's just another facet of your treatment. Just like I would send you to the cardiology when you need your heart checked. I'm going to send you to mental health because you have a problem with this.
Absolutely. And really, it sounds like when you have that supportive nature within the team environment, it's easier to normalize those things for the patient, because it's a support. Like even right now, you said, I have a team member who can be really helpful in this area.
Yes.
And as opposed to making it seem like this is going to be a completely different path that you're going to have to walk down, that collaboration from the team perspective really kind of has an effect on the patient's perspective on all of these different behavior, or all of these different approaches kind of integrating into one.
I recently heard a description of what we're talking about, and it was the description of, you know, how we in the field of healthcare have done this, really, because the person has always been a whole person, and we separated them, we meaning a long generations ago, into the 2 different camps, and so now we're trying to work to put them back to one whole person again.
Absolutely. Well, I want to thank you guys for all being here and for giving your input. I'd like to take this time to kind of ask if there's anything else that you would like to add to this discussion before we close.
Just that I think that teams can work in any setting, and the team members can vary, but that doesn't make it any less of a complete team.
Absolutely.
Whatever amount of team that your system can have and provide to a patient exponentially increases their care.
All right, well, thank you everyone for being here today.
Thank you.